As you are all joining today, if you can put in the chat where you're joining us from, it would be nice to see where everyone is from. And as we get started, for those of you that are newer to the hand therapy briefs, my name is Morella Deischer. I'm the founder of Virtual Hand to Shoulder Fellowship. The 30-minute briefs are something I just started a few weeks ago, and we'll continue coming week. Today, we're very lucky to have Brandy McCowan as our invited guest. Her specialty area is both wound care and lymphedema. And so our conversation today is really going to hone in on wound management. We'll talk a little bit about lymphedema because that's ultimately what led Brandy towards specialization in wound care as well. But let's just start out with learning a little bit more about you, Brandy, in terms of, I know you're an occupational therapist, but tell us how you moved towards the area of wound care and what you're doing now.
All right, Morella. Well, thank you so much for having me. So my name is Brandy McCowan. I'm an occupational therapist certified in lymphedema and wound care. So I have been an occupational therapist for 23 years, and I've been certified certified in lymphedema treatment for 22 of that 23 years. So the lymphedema world is definitely what drove me towards wanting more information and more knowledge about wound care, because what we found was that with a lot of those lymphedema patients, that wounds and lymphedema kind of went hand in hand. We saw a lot of wounds, a lot of weeping, a lot of lymphorrhea, being able to manage that exudate and then and start to heal those wounds was almost, it just went hand in hand, and you kind of had to do it anyway. So learning more and being educated more to be able to handle those wounds became imperative. I'm also an OT, so I actually do some hand therapy as well. And so I was kind of placing a little bit of my lymphedema skills in with my hand therapy patients. And I realized that when a patient would come in with those post-operative type wounds, what we would see is that I was really good at trying to get those to heal as well. Once we got some of the lymphedema managed, those wounds would heal incredibly quick when we were starting to apply some compression and some good wound management to those wounds as well. So the more that I progressed with the wounds, I became wound certified, and I now teach those wound certification courses and these lymphedema courses so that we can show other people how to utilize these skills to be able to manage and help a series of different types of wounds. Obviously, a lot of them associated with lymphedema, but many wounds all over the body, including the hand, arms, all of that type stuff as well. So it's been a fun journey getting to this point.
Yeah. So you're going to be speaking for the fellows in just a couple weeks. So I thought this was a nice kind of segue to having you present a lecture for them. What we do see in hand therapy is a little bit more those acute type wounds. We're not seeing, we see some maybe stalled wounds, and dealing with a little bit of chronicity for sure. But in terms of just the skill set that you think would add value for hand therapists within the context of wound management, do you see the need with regards to becoming a certified specialist? Do you think that having kind of a basic knowledge of how to manage wounds is adequate? Just thinking about the role of a hand therapist.
Well, I definitely think that being more knowledgeable in the area of wounds, and definitely even a certification in that area, is hugely beneficial to these hand patients. And the reason is this, is that when we can manage the wound exudate, okay, first of all, right? So most of us see tons of skin maceration around these wounds. We see a lot of necrotic type tissues. How do we get rid of that necrotic tissue? How do we manage that necrotic tissue? Do we need to debride that off a little bit? Can we help those surgeons in that realm, or are we constantly sending them back to be able to take care of that? Or are we able to take care of that on our own? The other thing is being able to add a little compression to those wounds. We teach a little bit even of some use of dual layer systems, such as like a Coban 2, to be able to wrap an arm if we have a whole arm that needs some compression. We use products such as edema wear, which is another wonderful product to manage edema in the arm. All of these things we teach in our wound certification courses, and so that we can utilize it for those acute wounds as well as those much more chronic type wounds as well, you know. And you'll see a little bit of all of it, but I definitely think there's a whole gamut to it, right? It's not just the types of wounds. It's being able to manage the wound bed itself. It's being able to manage the peri-wound skin. It's being able to manage the exudate and making sure that we've got dressing selections that are appropriate for that exudate. And when we can do all of that, those wounds heal so incredibly quick. And just not being afraid of a wound, right? So making sure that our whether it's a non-selective debridement or a selective debridement, that we're able to do that and conquer those fears of making sure that we're not going to hurt anything, right? With those type skills. So, you know, I tell a lot of therapists that, you know, they think, oh, great, I've got to use a scalpel. No, you don't necessarily have to use a scalpel with sharp debridement. Okay. There's a lot of other techniques. We use forceps, we use scissors, we use curettes, we use all sorts of other components to be able to debride that make a hand therapist's job a whole lot easier. I mean, I've treated all the patients with the saw injuries and the opened up palms and, you know, the amputation sites and reimplantations and all of those type things. And I use all of my wound care skills on all of those patients. So I definitely think that, especially our CHTs, it goes hand in hand. Those wounds go hand in hand with that. I always tell everybody, it's not a matter of if you're going to see them, it's when you're going to see them, right? And then the severity of them. We don't really know how severe they're going to be when they walk in the door. Okay. But being able to manage anything that walks in the door, any of those wounds that are associated with that walk in the door, is super helpful.
With regards to best practice in wound care, there's kind of certain things that come to mind when you think about best practice, just wound care in general.
Yeah. So, you know, I tell everyone, you know, everybody kind of freaks out about a sterile field. Well, you know, in order to keep a sterile field, it's near impossible, right? So in clinic, we like to use a clean field. Right? We're still using sterile type materials. We're using as much sterile as we possibly can, but it's not technically a sterile field because that's very difficult to maintain. So we're using a clean field. And so a lot of the time when we are doing those type procedures, we actually have like a closed off space that we are doing just that wound care portion of it. And then we'll actually move the patient to another space where we're doing more of the treatment part of it and their exercises and things like that. So it's kind of two separate spaces, especially when we have patients that are more involved, trying to keep as much of a clean field as we possibly can with all of those patients.
And is there like universal steps that you would say occur with every patient that you manage wounds with? Like, you know, beginning with cleaning the wound, like if you were to break it down in steps, is there a process that you can kind of describe?
Right. Well, you know, first of all, we're going to assess the wound. You know, we've got to make sure that we understand where the wound came from, that we understand. So that tells us our type of wound, that we understand the measurements of that wound, whether it has any depth to it, whether it has any tunneling to it, all of those type things. And how do we measure all of that, right? How do so all of it has to be measured. We have to be able to well document all of the wound bed itself. There's a lot of terminology that's associated with that wound bed. And then there's a lot of associated terminology with the peri-wound skin as well for that patient. So being able to know all of that. So we assess that wound, right? Number one, we assess it. We
Mhm.
find out how large that wound is. We also look at all the other comorbidities that are going to be associated with that wound, right? So doing a really thorough past medical history review to make sure that there aren't a lot of other contributing factors that are going to make this wound slower to heal as well, right? So is the patient a smoker? Are they diabetic? All of those things that we know slow down that healing process. So then, once we know what we're dealing with, well, then we need to definitely cleanse the wound. So we're using wound cleansers, we're using hypochlorous acids and things like that to be able to just cleanse the wound bed off. But first of all, we got to make sure the pain is controlled, right? So a lot of those patients, sometimes with these hands patients, we have these wounds and they're insensate, right? They can't feel them at all. Those nerves are cut. However, there's a lot of these that are sensate. And so we got to make sure that we're using a topical lidocaine, something like that, so that we can manage that pain level before we ever even start to work on that wound. Okay. And they're simple. Back years ago, we didn't have a whole lot of this over the counter stuff, but there's literally over the counter and it's just a spray. Right? We spray it on the wound, let it sit for a couple of minutes, and then you can work with that wound with no problem. So then we're going to wash the wound, right? We're going to cleanse that wound out a little bit. And what we never do with a wound is that we never take the odor of that wound before we have cleansed it. Okay. So everybody thinks, oh gosh, that wound smells really bad, but there's a soggy, nasty dressing on the top of it. And we've got to remove that dressing. Okay. Put it in a bag, close that off. We're going to cleanse the wound, and then we're going to pay attention to what the odor is past that point. Okay. So are there signs of clinical infection? Anything along that line, we're much more able to tell once we have cleansed that wound. We don't go with the assumption from when we take the dressing off. Okay. So then we're going to cleanse that wound, see what happens with any exudate or necrotic tissue or yellow slough, all of that kind of stuff. Some of that will come off with just a general piece of gauze when we're cleansing that wound. Okay. We get to that point though, and there's a lot more slough, a lot more necrotic tissue, things like that. So that's when we can start to utilize some of our sharper debridement techniques. Okay. So our scissors, our forceps, our curettes, or our scalpel, and being able to remove some of that necrotic tissue. The more of that necrotic tissue, the more of that slough that we can get out of that wound bed, the quicker that wound is going to heal. Okay. So then we've also looked at our dressing when we removed it, right? So is there heavy exudate? Was our exudate managed? Was it not managed? What are we going to do to put a dressing back on that is going to manage the exudate? And what does our peri-wound skin look like? Do we need a barrier film to make sure that we don't get as much skin maceration? It protects that peri-wound skin. Do we need a dressing that's going to be very wicking, very absorbent? What do we need? Do we need something that's just going to be a skin protectant, right? So like an adaptic and a non-stick pad. What level are we at? Or do we have a wound that is too dry? Right? Do we need to add moisture to that wound, because we know that moist wound bed is going to be the most healing, right? So do we need to add moisture? They have hydrogels and things like that we can actually add moisture to a wound so that it doesn't dry out so much, and really create that thick fibrotic scar tissue bed. Okay. So we're going to pick that dressing selection, right? And then we're going to be able to wrap over the top of that. Now, is there edema around that area? Are we managing that edema? Are we using edema gloves? Are we using compression bandaging systems that we would use in lymphedema, but I use them in hands all the time? To be able to wrap those fingers in that hand, sometimes even all the way up to the elbow when I've just got a hand patient. What are we doing to manage the edema part of that as well, once we have even gotten to the wound? Because this is what I tell everyone. The lymphatic system is like a garbage can, right? So when we get all these, that swelling down into those tissues, I tell people, I live in South Georgia, and I always tell them it's kind of like a mosquito pond, right? It's just nasty. Those are toxins that are gone into the tissues, and there's nothing really great hanging out around that wound bed. So there's all that congestion, all those toxins that are hanging around that wound bed. And so the more that we can get our trash can to function and flow, our lymphatic system to function and flow, the more that we can get those toxins out of there. So we add a little compression to that sometimes. And what happens is we get the trash to start moving out of there. But at the same time, we also get really good oxygenation. We get good vascularization to that wound when we add that little bit of compression as well. So it's definitely multifolded there when we're doing that treatment.
Yeah, and my understanding is that wound care is largely through chemical debridement, where we're using dressings for, to support autolytic debridement and
Right.
And even with like the necrotic tissue, that we can use enzymes versus sharp debridement, for example, to manage that.
Exactly. There's a product on the market. It's called Santal, and it's an enzymatic debrider, right? So if you get to a point where the autolytic debriding is not softening those tissues, not really taking care of that, then there is Santal that you can use as well. And the application of Santal, that's actually another code. So if you guys are using, if you're using even a piece of gauze to cleanse that wound out with, or using a Santal, or using autolytic debridement, and you're still cleaning that wound bed, there's coding that we use for that. It's 97602. It's non-selective debridement. But that's still debridement. Okay.
Mhm.
And being able to know what to put on top of that. What do we put for the most effective use of the Santal? What are we going to use to make sure that we have the best autolytic debridement without maceration? Those type of things are super important to know. And that knowledge base is extremely helpful when we're treating these wounds as well.
Is there anything in wound care that's kind of fallen out of favor in wound management?
Yes. So wet to dry dressings, right? So there's a great article. I can send it to Marilla. It's called Hanging Wet to Dry, Out to Dry. So a lot of people still love Dakin's solution, right? You guys, for starters, Dakin's burns. All right, it burns. The other thing is there's so much other stuff out there that is so much better than Dakin's. It does not hurt the patient. We do not have to have a wound that is packed with Dakin's solution. Okay, there are so many other things out there that are so much better for the peri-wound skin, better for the wound itself, and then overall better for the patient because they don't hurt. Okay, so if I don't know how many orders I see for a Dakin's wet to dry, and it makes my skin crawl every time that I see it.
So I've been in clinical environments where they still use, and this is at the preference of the referral sources, they use Whirlpool, and I'm curious about, yeah, okay. I would love for you to talk about Whirlpool.
No, I have not used a Whirlpool, and I can promise you 15 years.
Yeah, that's about when they started indicating
it's a cesspool for bacteria.
Yeah,
it is a cesspool for bacteria. I have seen more, back when we did, back when I first became a therapist, Whirlpools were rampant. I mean, rampant everywhere. And so, but I cannot tell you the number of pieces of gauze with stuff still stuck on them we have found up in the agitators. And you're thinking, I just gave every other patient I used that with, because you don't break the whole system down every time you cleanse it. You were washing it, right? And you were running it with that solution, but you didn't get that piece of gauze that was stuck up in there, right? Or something that clung to the side. No more Whirlpools.
And as far as cleansing wounds, is like a saline solution adequate? I know you mentioned some other types.
Right. So saline solutions are adequate if you're actually using a they have sprays that are more of a saline solution. They have that are like a aerosol type spray. They have some base spray. They have some that are trigger sprays. I'm a big fan of Vosh, which is pure hypochlorous acid, which is really, really good to clean those wounds. And it's really good. Sometimes I actually will. So if a doctor just really wants that wet to dry dressing, I will concede to a Vosh wet to dry versus a Dakin's wet to dry. Okay. Just a much different format for breaking down those tissues. The Bosch is very, very good and antimicrobial as well. And so what we find is that it helps with some of that bioburden that gets in those wounds as well. So a lot of time I'll take the Bosch and I'll actually put it on a piece of gauze and I'll let it soak on the wound for a little bit.
Mhm.
And then I'll debride that off. Whether that's just with another piece of gauze or whether I'm using some sort of tools or anything to actually debride that with. I also like Anisep. All
Mhm.
right. It's also got it's kind of a bleach solution as well. It has a very bleachy smell to it, but not near as strong as the Anisep. There again, it's not going to burn. Just a little bit different format there. There again, there's some wounds that it's not real. It doesn't seem to have a lot of bioburden. There's not a lot of slough, all of that kind of thing. And I'm probably just going to stick to my regular saline type wound cleansers for those and not use the more expensive stuff.
Okay. And is it still like with regards to assessing a wound and looking at, whether it's red budding tissues,
Right. So granular.
as a guide to how you're going to manage that wound versus, a wound that has slough and exudate. I mean, those are the kinds of things that we're using to decide even the cleansing process, right? So if it's a healthy looking wound, what's your recommendation there?
If it's a healthy looking granular based wound, that beefy red type color, then I'm definitely going to just clean that with a general saline type wound cleanser. Nothing special, right?
Okay.
If I've got a wound that has a really thick slough base to it or necrotic base to it, I'm probably going to use something more like the Bosch or the Anisep to make sure that we get that nice and cleaned out. Those are more antimicrobial. We're going to find that they're going to cut down a lot of that risk of infection with those wounds versus just the regular saline wound wash that we can use with that.
Is there anything that we, like as therapists, we get patients that are post-op, let's say they're post like a Dupuytren's fasciotomy, and we want to ensure that there's good tissue healing. What are the kinds of things we want to be thinking about related to that healing tissue, even related to the stressors that are placed on it?
So the stressors that are placed on it obviously have a lot to do with it, right? So we all know that you don't want to pull into too hard of extension, all of that kind of stuff. But you're also making sure that you are ensuring that you know how sometimes when we see those suture lines and they're in that Z formation, right, on those Dupuytren releases, that we want to make sure that the Z's aren't staying too wet. But at the same time, we don't really want them too overly dry, because what happens is they kind of crack and pull apart a little bit. So I'm a huge fan of vitamin E oil. So and we use this in practice from time to time. So we'll start to put even just a little bit. If it starts to dry out too much, we can either add a hydrogel, or you can add a little bit of a vitamin E type oil along the very edges of that wound. And if it gets in the wound, it's not harmful. It's vitamin E oil. It's okay. And then covering that with like an adaptic and a non-stick to make sure that we don't have any areas there. So with those incisions like that, if it's exudating too much, we need to manage the exudate so that the skin doesn't become macerated, because then it won't heal. But at the same time, we want to make sure that it doesn't get too dry as well, so that those wound edges will go ahead and mend back together, versus getting that thick callus type skin that we see on the palm of the hand a lot of the time, that tends to want to kind of turn up a little bit. And a lot of that's going to come off. We know that those under layers of that skin are going to heal back nice and easy, but it's a lot easier if we can keep that from ever getting so thick.
As far as like a complication, one of the things that I've observed is like tunneling. So how does that happen? What are the things that kind of set that in motion? Are there early signs of something like tunneling? And what can we do to like mitigate it, number one, but then also once we see the potential that it's evolving, how do we manage that?
Okay, so most of the time we're going to see tunneling, especially if we start to see any wound dehiscence. So remember that, especially if we have had any kind of large wound that had to be closed, right? So the tissue technically is supposed to heal itself back down. So there's a closure line, but we know that everything around that area was kind of, we had some problems with as well. So you got to realize that the surgeon worked everywhere in that tissue, and there's a large closure line, but everything back from that. So we make sure that we always palpate around that wound, okay, or around that incision line. A tunnel is going to feel very boggy, right? So if we're feeling that tissue and we get to an area and it's boggy, right, you're going to pay real close attention to that. And then watch out, because what you're going to find is that your suture line right there, closest to that boggy area, is probably has a little more exudate in it. And the other thing is that it starts to feel boggy as well, right? So you really have to pay attention to those boggy areas, and then watching your suture line and seeing if those kind of line up with that to make sure that we don't have any tunneling there as well. You know, as soon as you suspect tunneling, the best thing that you can do is, you know, definitely make sure that the physician knows about it. Okay. But then we get those sutures out and then we start packing that tunnel. Okay. So packing of that tunnel is the best way to mitigate that. Make sure that we don't get any bacterial type infection that wants to harbor down into that tunnel. And you need to pack that tunnel tight enough so that it has enough growth room to come all the way back out. So I like to change a tunnel packing at least every day to 2 days when we're doing something like that. So we teach the patients a lot of that as well.
Interesting. Well, I want to respect everyone's time. I know we're at the 30 minutes. We have a few minutes. Does anyone have any questions that you want to direct to Brandy on wound management?
You know, I was seeing this, they were using Dakins on Pseudomonas. Vosh and Anicept work just as well, if not better, on Pseudomonas. So I actually was just at a wound conference this weekend in Las Vegas, and I saw a wonderful presentation on pure hypochlorous acid, which is Vosh, VASHE. And the results were absolutely phenomenal with the Pseudomonas as well. So are there any other questions? I think that was all of those, right?
Well, before we end, if people are interested in learning more either about the lymphedema or wound management and the process of becoming certified, I know you offer international classes and also online, right?
We do. So I'm actually the CEO of International Lymphedema and Wound Training Institute. I'll put the website in the chat in just a second. And we do offer a wound certification course, lymphedema certification courses as well, that are entirely based via teletraining, right? So the entire thing, even the debridement lab, all of that kind of stuff, all the supplies are sent to you. You do have to have a few little supplies like a ham hock, that type of stuff. But everything else is supplied to you, and it's all done via teletraining. We train students internationally. We've got a student right now who is with us. We're finishing up a certified wound therapist course this week, and he is from Rwanda. So it has been fun to work with him as well. So we would love to have you guys. You go to ilwti.com, and I created a code just for you all. So it's called HAND15. HAND is all capital. And let me make sure it's HAND15. Hang on. HAND15. It's HANDS15. Sorry about that. HANDS15, and that'll give you 15% off of any of our registrations for those courses as well. So here is our website. And then HANDS15 is the discount code for that certified wound therapist course.
Perfect. And we're really looking forward to having you speak soon again for the fellowship. Thank you so much for your time. And thanks everyone for joining again today. Keep an eye on the times. I might change the time because we're going to have different guest speakers that are not guest speakers, but sessions like this. Therapists that have, specialty niche areas and they're going to share their expertise. So just keep an eye on the time, but we'll continue with these weekly hand therapy briefs. And again, thank you, everyone. And thanks so much again, Brandy.
Thank you so much for having me, Marella.
Yeah.
You all have a
Thank
wonderful
you.
afternoon.
Bye, everyone.
Bye.